Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answers. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. To grow this community of information and action, I hope you give us a 5-star review. Come visit me on hightruths.com to learn more about the show or download a free prescription for naloxone. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Today's episode is sponsored by Physicians for Healthy Communities, a physician-led organization that educates on the science of prevention to improve public health. Visit their website to learn how they prevent substance misuse while supporting individuals, families, and communities. Go to physiciansforhealthycommunities.org. Hello again, High Truth listeners. Get ready for a policy conversation. I'm your host, Dr. Ronit Lev. Policy as in drug policy. How important is drug policy and what effect does it really have on our society? There's a philosophy that says all drugs should be legal. And there are those that take it even further and want drug use normalized and commercialized. The motto I've heard is, you have your wine, I'll have my line, as in line of cocaine. That is the camp of George Soros and Drug Policy Alliance. On the other extreme, there are countries with very harsh and strict drug laws, even the death penalty for selling drugs. The United States is in the middle of these extreme drug policies with the push toward drug commercialization. I see that push with advertisement at every corner for weed. Is that good or bad? I like learning from history. Let's look at how drug policy affected tobacco and health. Tobacco is a plant that has been around since prehistoric times. Christopher Columbus brought it back to Europe after discovering America. And tobacco was commercialized, normalized with peak use in 1963. Americans used 523 billion cigarettes that year, and 42% of Americans were regular smokers. 42%, that means most people were not smokers, but it seemed like everybody was smoking. Then, in 1964, the U.S. Surgeon General Luther Terry released the first advisory on smoking and health. The advisory came 14 years after the first epidemiological studies showing an association of smoking and lung cancer. And in the wake of the Surgeon General's report, Congress adopted the Federal Cigarette Labeling and Advertising Act of 1965, and then the Public Health Cigarette Smoking Act of 1969. These drug policies made a big difference in curbing tobacco use and decreasing associated health consequences. The tobacco lawsuits then helped fund the Truth Initiative that continues to work today in preventing tobacco use in youth. Tobacco policies helped decrease smoking from 42% at the peak in 1963, 21% in 2005, and now 11.5% in 2021. Can we learn from tobacco drug policies to work on marijuana and other drug policies? To learn more about drug policy, I reached out to a world expert, Dr. Rosalie Liccardo Pacula. Dr. Rosalie Liccardo Pacula is a professor and chair in health policy, economics law, health policy, and management department at the University of Southern California. She's a national leader in studying drug policy and assisted key organizations such as the CDC, the National Institute of Drug Abuse, SAMHSA, the Substance Abuse and Mental Health Organization, the World Health Organization, the National Academy of Medicine, and the RAND Corporation, as well as others. To learn more about Dr. Rosalie Liccardo Pacula, check out the High Truth show notes. Dr. Rosalie Liccardo Pacula, welcome to High Truth.
Thank you so much for having me. I'm sorry it's been taken so long.
Good things are worth waiting for. You are a very busy lady, and I had to book you, half a year in advance or more to be able to chat, but it's very, very well worth it. I remember when I got to meet you, we had dinner together in Washington, D.C.
I was thinking about that. Yeah, that was pre-COVID.
That's right, pre-COVID with Wilson Compton, and said, okay, you have to meet this person, and it was you, and the rest is history. And then I see you again, not in the United States, but at the United Nations in Vienna. So I guess I chase you around, and so glad to have you here on High Truths.
Well, thank you for having me.
So your expertise is unusual. You studied economics, and just tell us about yourself and how you get from, a degree in economics to being a world expert on drug policy.
I've had really good advisors. Basically, economics is the study about markets and the allocation of resources within markets. That's in principle. But markets happen because there are suppliers and there are consumers. And so there is a lot that we need to understand about the nature and behavior of suppliers and consumers when we're talking not just about any normal product, but particularly intoxicating products. So I was blessed to have some amazing mentors, Phil Cook, Frank Chalupka, who are also economists who have been studying the demand for intoxicating substances well before I did. And I just really gravitated to the topics because they're far more complex than standard goods that you buy at the marketplace. You buy milk, you don't think about it. It's just a regular commodity. But there's decisions that have to get made when the product is sold in an illicit market, and not every consumer is willing to go there. What causes the consumer to go over that threshold? And are they comfortable buying a product of unknown certainty? So these are some of the interesting facets about these illicit and intoxicating markets that have generated my interest for quite some time.
So early in your career, you were introduced to the issue of drugs as a...
Back when I was doing my dissertation at Duke University, I was working with Phil Cook, who at the time was studying alcohol policy in the United States, and wrote a book. And I was fortunate enough to be one of his research assistants. And at the time, the U.S. states had only decriminalized cannabis, and not much had been considered about what was the impact of decriminalizing cannabis on alcohol consumption. And so he kind of nudged me. He said, hey, if you need a topic that's interesting for a dissertation, that might be a good one. And that's where I started.
Very good. Very nice. So nice to have important mentors I've had in my career as well. Your question and view of drugs as an economy reminds me of a question that we had during our season finale, where someone said, what is it about the United States where we have this greatest consumption need? I don't know if it's a need. Using drugs has been, from the dawn of time, people have used intoxicants, but we are the world leader by far. And what is it about us? Is it because we're a richer country and poor countries don't have the money?
That's a big part of it. Income. Economists spend a lot of time understanding how income influences consumption, particularly of things that are enjoyable. And most intoxicating substances are enjoyable the first few times, different thresholds of when they become no longer enjoyable to the consumer because the consumer loses control, but that depends on the substance. But fundamentally, there's an income aspect to it. Now, obviously, you look in the U.S. and there's a lot of individuals who would appear to be of lower income also using intoxicants. That's not the only explanatory factor. It's also this sort of need or compulsion to deal with the stress that we incur in our lives. As a developed nation, we aren't as struggling as much with just getting food on the table. That's not true for everybody, obviously, but as a population wide, those sort of struggles are not as innate. And so when you're in another country where your focus is really about getting food on the table and getting clothes and shoes on your children's feet, there's less ability to take the time that's required to use some of these other substances, because another input in the use of an intoxicating substance is the time that you can lose while you're intoxicated. You're not going to be able to do other things while you're intoxicated, or you shouldn't be doing other things. And so that's another one of our privilege. We have more time to do substances. We have access to them because it's a rich economy. There's access to these products. And unfortunately, the income. There's also obviously a very strong social nudge that this is part of our culture, ability, with our wealth can come the ability to engage in things that are, looking for the word.
What about the concept? Because I focus also a lot on prevention, primary prevention. What about the principle that life has struggles and you learn to deal with that with other ways, talking, exercise, other ways of soothing rather than going to a drug?
I think that's a very good point. We have had less of that. I think marketing has really taken over a lot of our psyche and how we should handle various stressful situations. We're being told how to do it based off the sell of certain commodities. And unfortunately, we're buying into it again, because we're looking for, I think one of the issues of our society is we're looking for the quick fix on a lot of these things. Things that take a lot of work where we don't want to have to do because we've been blessed with so many innovations that allow things to happen more quickly. And unfortunately, I think the same is true for some of our behaviors when it comes to using intoxicating substance or fatty foods or exercise and the like. We're looking for a quick fix to solve the problem external to us instead of doing the internal work that's necessary to manage those decisions.
Yeah.
But that's outside of my discipline, so I shouldn't speak too much about it. But as economists, we do recognize these steps.
But I think these are things that are important because we are the leading consumer of drugs. We haven't always been that way. When we started the real opioid wars with China was a leading consumer of drugs, specifically heroin that came from the United Kingdom and France, and that created the whole
and their neighbors. And so some
opioid
of
wars, right?
It
and then that led
trend.
to what we're doing with the United Nations, right? Is creating global drug policy because of those wars and how things have changed, right, over the years from China to being the biggest consumer and the West being the suppliers to the other way around.
Yeah, but part of that was because China had a very harsh crackdown domestically that shut off their consumers and suppliers elsewhere. And some people would say that it's overly harsh because of the human rights violations that occurred. But again, policies are part of the reason why our market is open to so many intoxicating substances. And a big piece of it is our free market allows for products to come in ways that other countries have more protective barriers. I'm not saying that's the best strategy for it. It's just one of the realities we have to face in our market.
Yeah. And you're talking about how, again, what is it, the 1800, 1900, where China had a good percentage, especially of men who were using heroin and the opium dens, to a complete reversal where they started producing the heroin and they cracked down on the users. Yeah,
I mean, China was always involved. China got hooked on the opioids because of trade, right? It was a part of the trade agreement with Europe, and that's how they developed an interest. When they cracked down on that, it was no longer as readily available. Its neighbors started producing. I've never thought of China as being for an illicit producer of opioids. It's not as large as some of the other neighboring countries, but it is an important country because it's a very large country with a lot of potential consumers. So,
yeah. So you right now are at USC at the Institute of Addiction Science, and you lead a group on addiction policy and health economics. And you kind of gave us an explanation of that. But what does that mean? What do you study at the Institute?
So actually my official positions in our School of Policy are the Sol Price School of Public Policy. But at USC, there's a genuine interdisciplinary cross-school effort to integrate all the different disciplines who are working on aspects of addiction, whether it's the medical, the health services side, the psychology and sociology, the prevention, and then economics and health policy more broadly. So because I sit in the School of Public Policy, a lot of my work and research has been really evaluating how different state and federal and sometimes local strategies, policies, regulations, moratoriums, decisions that affect the consumers in those jurisdictions. How do they influence intentionally and unintentionally the behavior of both suppliers and consumers within those markets? From a public health perspective, we've in the U.S. had the exception of alcohol and tobacco, have had very much a prohibitionist perspective for many, many years, although not our full history, obviously most of just the 20th century. And as we're opening up these markets, there's this swing, I think, to a reaction to the very harmful negative consequences that prohibition of some of these substances has caused, and a neglect or an afterthought to how do we adopt regulation such that the marketplace acts in a way that is better for consumers. So consumers consume a safe product that they understand, and that they can then, with that understanding, make decisions on appropriate use for their own. Ultimately, economists believe that individuals are the best people to make decisions about consumptions based off of their own information and their own budgets and situation. However, if there are instances where the consumer is not fully informed, then economists recognize there might be a need for market regulation to try to.
But Rosalie, using your alcohol example, we can debate prohibition. We obviously living in a world where we don't have that, but there is a standard for alcohol that's practiced around the whole world, where I'm not afraid that I'm going to drink a glass of wine or whiskey and get, blind from methanol poisoning, right? Which we had before that. So there is a very
strong
reliable, very reliable
regulations.
safety regulation that goes throughout the world. We do not have that for probably any other drug.
Tobacco is pretty tightly regulated itself, the cigarettes, I would say. But we're struggling trying to implement it for vaping products. And obviously for cannabis, the issue of psychedelics is beginning to bubble to the top. So some of this is twofold. We've had a lot of time with alcohol where it's been legally regulated in multiple countries and learned best practices from each other. And we've also been informed of the issues of certain ingredients in alcohol. So it's not just that the products get approved and are tested, but there's regular compliance checks to ensure that the products being brought to the market are indeed the products that the consumers think are coming. Mm-hmm. We haven't reached that stage at all with cannabis yet, in part because we don't have a federal partner in the U.S., but even in other countries that have adopted this, the knowledge needed to know everything about this proliferation of cannabis products is not there yet. We have so much to learn because the products are diversifying faster than our information about them.
Right. So, one thing, like you mentioned, doing well with alcohol and having more time with that is the standards of the product itself. Mm-hmm. But when I'm looking at health policy, I always, for our current American history, I look at tobacco. And I'm wondering what you think of what we've learned from tobacco policies. At the peak of tobacco consumption, we were at like 42% of the population was using tobacco. Now we're down to 11%. And that's largely by good policies.
Well, a huge public health campaign educating smokers about the risks of smoking. I think that's been a big part of it, more so than policies, because individuals aren't necessarily pleased when policy gets in place telling them what they should and shouldn't do. But when they are simultaneously informed about the product and why those regulations are helpful, then I think they're more willing to accept them. In the case of smoking, we had decades of research of the health risks, but a very viable tobacco industry that was able to market and campaign its product in ways that reached the consumer more directly than the medical messages did. And it took time to overcome that. And, the big knowledge of the tobacco settlement and the truth campaign is we needed to figure out how to communicate the health risks and the fact that the tobacco company earns its profit by getting people hooked. It's not the casual smoker that helps them earn a lot of profit. It's the regular, consistent smoker that's smoking a half a pack or a pack a day. That's where they get their profit. And that's true about most intoxicating substances. Casual users are not where the cannabis industry is going to get its profit revenue. It's from individuals who are choosing to consume on a more regular basis, a daily basis. Now, when we think of a medicine, we don't worry about daily consumption, but that's in part because that medicated period is usually short-term in duration. And again, the company knows that. There's few pharmaceutical products. There are some where you start them and you are going to be on them for a long time. But in that case, we don't have that pharmaceutical company then trying to get more and more consumers who don't have certain risks into that product. And that's the gray area we're in right now with cannabis, quite honestly. And one of the struggles.
Well, I don't know. We had a lot of damage, right? About 100 years of tobacco damage before we kind of came to.
And you would think we would learn a few things from.
Or at least make it, but we did learn, right? The marketing strategy to children is even better. The products are better.
Packaging matters. Packaging matters.
Right.
Where you place advertising. We do know these things. And outside of the U.S., you have places like Canada and Germany. Canada's been legalized now for 5 years. Germany is about to open their markets, and they're using that information and setting up their marketplace. In the U.S., it's been a different process because of the lack of a federal partner and because of the lack of science right now regarding the health impact of particular cannabis products. We know the most. I
wonder why you say there's a lack of science on the health impacts. I'm an emergency physician. I see cannabis poisoning every single shift. I don't see how we can have lack of science except for, we're not coding.
That's a big piece of it, though. That is exactly part of the reason why the science can be deemed not sufficient. Part of this is that where cannabis is not that big of a problem or doctors are not aware of it, they don't code people who are coming in for cyclical vomiting.
Because there isn't one. We only this month was cannabis hyperemesis syndrome submitted to CMS as a code.
Correct.
This is something that every year I see like 2-3 patients a day, at least, some places more. And yet, it's not even going to happen. I don't know if we'll have it for 2024 or if it'll be 2025.
But part of the problem is doctors not all doctors being aware, and there isn't a coding, but some will code a cannabis use disorder with that, but it takes them coming to the ED or to their doctor several times for the doctor knows that cannabis use was also involved in the cyclical vomiting. Some of it is that we don't know what the product is that they're consuming because, and that's again, going back to, we need a lot to inform the consumers. Some of these products might be more associated with cannabis hyperemesis than others, depending on who is using them and how frequently. We know that cannabis hyperemesis is triggered by more of the high potency products. So just asking about cannabis use is like saying, do you use dairy?
Well, I think we know enough as an ER doctor who does this all a day. It's you ask, are you smoking? Are you using edible? How often, and for how many years? Because cannabis hyperemesis syndrome is very much like the opioid hyperalgesia. So I've lived through that with the opioids, and it wasn't the person who takes a pain pill after surgery who's getting their neural pathways all messed up. It was a person who's been using high doses for many years, and it's the same thing. It's the same phenomenon, right?
Absolutely. But if you're using something that is really, really low dose for a long period of time, do we expect to see as negative a health outcome as something that's I'd say low dose, I mean low THC?
I don't know. Did we do that with tobacco? Did we say, oh, it's okay for you to smoke 2 cigarettes a day, but not 50 cigarettes a day? I mean, 2 packs a day. when we sounded the alarm on cancer and heart disease, you can, I don't
There's
know.
a dose response relationship with tobacco, with cannabis, and what we don't know is different health events are tied to different components of the cannabis and how it's being used, right? So getting an absolute dose response, something that we can simply convey to consumers of don't do X, given there's more than 140 different types of cannabis products out there. How do they know that it applies to their product, to all the products?
But we kind of saw that. I mean, I could see where you want to get that granular kind of data and information out there. But I think that it's enough to say, it's like saying, okay, regular cigarettes versus filtered or, low, the light cigarettes are better. It's like, wait, no, all those can cause heart disease, right? All those cannabis products used regularly can give you psychosis, and it's a risk factor. Not everybody who smokes is going to get cancer or lung disease. Not everybody who uses marijuana is going to get schizophrenia. But, a 4-point-fold increase, that's significant.
Yeah, but that's also because of the products that are available in the marketplace here. That's why we're seeing it. It's not, that's the piece that I think.
But our data is from Europe, and they considered high potency 10%. For us, that's low potency.
Yes, agreed for many products, but there are some products in the cannabis space that fit that bill. So my point is just that we do need to be careful in communicating. And the problem is researchers are still struggling with what those thresholds are. We don't know how much. You and I are having this discussion, and I'm not saying no, it's not. I truly don't believe that. I believe there's harm coming with excessive use and prolonged use, but what is that threshold? And I get asked this all the time. I don't think scientifically we have an agreed threshold. We, in Europe, like you said, they have a 10% threshold. In the US, we've been letting industry decide so many of our thresholds, whether it's how much THC in an edible or in a package. So ours are likely to be higher. So if you're talking about just the US, sure. But if we're going to talk globally, we have to be a little more specific because globally there are other regulations in place that mediate the potential harm of the products because they're more willing to regulate which products are allowed in the marketplace.
That's interesting. You raised some good points. You advise the United Nations on drug policy as a...
I wouldn't say advise. I spent the last 4 years as the president of the International Society for the Study of Drug Policy. So this is an international group of researchers from a variety of different disciplines, focused on studying all sorts of legal and illicit drugs, but a lot of them are more focused on illicit ones. And as a scientific body, it's our goal to bring good science forward to policymakers, which is what we've been trying to do for the last several years at the UN conventions.
And I know I've heard you discuss it before, that the issues are complex, especially as a researcher and scientist, that you are trying to control for all these things that you can't control. Maybe go over that with us. I've heard you say the complexity of the market, the outcomes, the policy, even the study methodology.
So I'm really jealous of people who get to study things in a lab where they have complete control over the environment, because then you can really assign a change in a lab rat or even somebody you're bringing into the lab and observing to what it is you're trying to attribute it to. As a social scientist, economists and other social scientists often use natural experimentation across populations and groups to try to infer an association about the availability of a product or the use of a product on potential harms. And we have to acknowledge that there's other factors that can also conflate the association. And so there's a number of, large body of research in many disciplines trying to address how do we do a better job of isolating some of this noise the way you would in the lab, but we have to do it statistically to try to get a better sense of that relationship. And it can be done in some ways, in some instances very well, and in other instances less well, depending on the issue being studied and the number of factors that are changing at the exact same time. And our methods for doing that have been changing, just like technology in other ways. We thought we had really reliable methods 10 years ago where we can compare two jurisdictions, both trending along the same way. One adopts a policy, the other one doesn't. What's the difference in population effects between these two? But what we learned is that those methods are not always as reliable as we expect if we don't statistically check. It's like saying just because you're randomized in the RCT, randomization automatically works and takes care of everything. Actually, you should always check and make sure that you have your randomization work to make sure that you have the groups looking very similar on observables. And that's what we are learning in the social science. We have to do a better job of checking that. And unfortunately, a lot of the research that's been done examining the effects of marijuana and cannabis policy in the U.S. has been using some of those old methods. And so that's part of the reason why you're hearing me hedge a little bit about the body of the evidence, because I think that a lot of those studies are going to be reconsidered. I know a few of them already have, and the results aren't as consistent as they were before.
Can you explain further what you mean by that? Do you, because I probably have the bias of looking at the health effects, but I see, hundreds of publications, and it's not disputed the health effects on the unborn child.
So you would be surprised.
Yeah.
There are a number of studies, and this goes back to what is a strong study and what is a weaker study, which is part of what we've been trying to educate policymakers about. There are a number of studies that have associated changes in cannabis policies with birth outcomes, but they don't have the middle factor of the mother's actual use. They aren't linking the mom to the birth outcome. So when you look at those studies, there's not as strong of an association between marijuana policies and negative birth outcomes for the child using very advanced statistical methods. But the problem is the data isn't that.
But what about the ABCD study that shows that?
Exactly. So that goes back to a good study has really good data on the mechanism through which you think this policy change matters. In ABCD, you have the mothers and you have the child. So you know directly what's happening. In the case of work that's being done at Kaiser by Kelly Youngwolf and her colleagues, she has information on the mother and her testing during the pregnancy, because all of us who have had kids know you get tested lots of times just for checking your regular progress in childbearing, and then connects that to the birth outcomes, and you then see much clearer negative impacts.
So isn't that enough?
It's enough for somebody who can parse through that science and say that's good science and that's bad science.
But don't we have enough information today to say it's probably not a good idea to smoke pot while you're pregnant?
You would be surprised how many meta-analyses and reviews say it's unclear, because they pull the studies that don't have that direct mechanism and give them the same weight as the studies that do. And that's for me, what's scary. We should be giving greater weight to the stronger studies so it is clear. I think you're looking at it
saying
and going,
that there's some people, probably the industry, who knows how to twist the data around.
It's not just the industry, unfortunately. There's a lot of people. Economists are not experts in health. They don't know. We like to use quasi-natural experiments. It's a cute identification strategy. But if we don't check the mechanisms, we can't be sure that the association is real, even if our methods are really, really robust.
So
our methods are robust to data. A good study, my point is this. We need policy made off of good data and good methods. Unfortunately, this is a topic that is polarized. People have strong views, whether they understand the science or not.
Right.
And they find studies that support their views.
Okay.
Some of them have better science. Some of them have poorer science. But the policymaker is not well educated to know that they're seeing both sides advocating using published studies, and they don't know how to decipher it. And I've seen literature reviews conducted by researchers who don't know how to decipher it.
I
So
see what you're
that's
saying.
why
I
there's
get
a
it. Because
push to try
you
to
take your
improve that.
point of view, you're pro pot or against pot, or I'm pro health, and then you can push the data around, the or the
Or you
studies
can
around
find a
to
study
your
that
point of view.
supports your opinion instead of looking carefully at mechanism and quality of the data as well as quality of the methods. Say, oh wow, and all that matches up. It's a very clear story.
Well, I feel like we are living history again with tobacco, because that's exactly, if we, were to time travel back in a time, then we had the same arguments. Those lungs are black. They're not black from tobacco. Who said they're black from tobacco? And I've actually seen medical examiner death certificates where there's a little box that says smoker, not smoker. And I could imagine that someone passed a law back in the day saying, we're going to do this study, we're going to prove that these lungs are black, by getting this data. And we're gonna hurt a lot of people. In the meantime, there's going to be a lot of victims while we catch up and win or lose these arguments over statistics.
But I don't think it's what's unusual about this is the delirium, I would say, about the industry and how wonderful the industry is. We see this with herbicides. We see this with new consuming products all the time. There's the next best Nutrisil. This is going to help you with weight loss. And they're promoting it before anybody has done the careful science, because the only science out there at that point is whoever the company was that pushed it. So some of this is a nature of how our U.S. market is allowed to operate. But some of this is also a function of the fact that cannabis is a really complex product. It does the individual ingredients in the plant may be known, but not necessarily all the derivative products that are being derived from it. And it makes sense. A natural first thing is, and why I used to hear a lot of public health campaigns, is start low and go slow.
Like opioids.
With health, usually things in small doses aren't going to have a huge effect on our health unless they're really poisonous, right?
Mm-hmm. Right.
And unfortunately, we have an industry that's promoting the opposite, and consumers are not getting the information they need to make better choices. They're forgetting that the reason why they're being advocated to use these higher potency products is because that benefits the industry, not because it's necessarily beneficial to them.
Right. I definitely agree with you there, like 100%. The reason I like talking about marijuana is because the information is hidden from the public, right?
Yeah.
I like talking about opioids before it was fashionable to say that doctors are overprescribing. When I started talking about opioids, I was, villainized, like, what, you don't care about your patients, right? And now I guess I'm ahead of the curve here. It's just a matter of, like, you should know your risk for mental health. You should know your risk for heart disease. You should know about your drug interactions. Just yesterday, I took care of a guy who was like, he couldn't drive right, and he had achy, and he couldn't think, he couldn't explain, and maybe it was his alcohol, and he blamed it on all sorts of things. And it's like, let's check your duoxetine and your cannabis. And I just had him read for himself what it says on drugs.com. It was a dissertation of all his symptoms. People don't, just for you to know.
Mm-hmm. Yeah, no, I that is absolutely the case. We trying to figure out how to educate the consumer is going to be tricky, because this is one where the consumer believes there's centuries of data showing this product is relatively harmless, but the product that they're referring to is not the same product.
Doesn't
on
even
the
exist
shelf
anymore, right?
Yeah.
Wait, I have an idea as you're talking? Does your institute do advocacy? Like, if we had, you're in California, if we have California legislation, do you write in letters of support for this or that? Are you allowed to do that?
So for 21 years, I was at the RAND Corporation, where I co-directed RAND's Drug Policy Research Center for 15 years, and I was not allowed to engage in any advocacy. At USC, it's not restricted, but I've come to appreciate the fact that people will ask me questions because they know I'm not advocating when I say that there's health risks associated with something. And here are regulations that are in place in other countries to try to reduce those risks that could be feasibly adopted in the US. They are more willing to listen because they don't think I'm trying to change prohibition or change the legal market. Right. I'm not about extremes. Yeah. Markets can be influenced by the extremes, but they can be influenced by all the policies in the middle too.
Right.
And that's why I find it fun to study.
And I like that. The view of an economist versus obviously my view as an emergency and addiction physician. But the idea I have for you is, we're both in California. We've tried now for 2 years and failed to pass any legislation, about kind of like taming down regulation on the cannabis industry. We have not passed a single bill since 1996 when marijuana was legalized medicinally in California. Nothing. The industry has been able to create like a whole like the products that are being sold today didn't even exist in 1996. It's not at all.
We've had a few minor successes, but I wouldn't say that they were things to be excited about. I agree. I think we have a lot of work.
2 years ago, we tried to put product labeling like we have for tobacco and alcohol. That failed. This year, we tried to protect, packaging. This year, we tried to, 2023, we tried to save children because of all the babies we're getting into all these candies. Like, why do we need, little Cheetos that look like Weedos or whatever?
Twinkies that looks, yes.
Right. Like, why do we need that? Who's that for? So this year I have a bill that I wrote. We'll see where it goes. But that will require pharmacies. It's again for drug interactions to put a auxiliary label, like we have, like don't use with alcohol. This would say don't use with cannabis products.
I think that's a great idea.
Right? Will you support that?
Oh yeah, absolutely.
Awesome. And it's very easy. I'm working now with the Pharmacy Association to get the language so they don't feel threatened by it.
We know a whole lot more about interactions between medications, and I think that educating it's just an effective way to educate the consumer.
Right. Unfortunately, I did a little study to see if people want to. We sent 10,000 info cards to patients at pharmacies when they were picking up their pharmacies and asked them through a QR code, would you want this information? And 95% said, yeah, we want this information.
Yeah. No, I think it's a very effective strategy. Again, you're educating the consumer, you're helping reduce those information.
Right. I'm not telling you to use, not to use, just be aware.
Yeah.
Medical versus recreational. And I know that you've kind of tried to study that and, what's a dose? Like you said, is it a 10 milligram per dose, 100 per package, medical versus recreational? Again, as a physician, I have maybe different points of view than what our government thinks of medicine. I feel like the government's playing doctor a little bit here.
It's really fascinating to me that we have consumers advocating for tighter restrictions on some products, yes, on others. But the medical recreational distinction in the U.S. is difficult to explain, particularly to people in other countries, because we don't operate our medical markets at all the way we would any of our other medical products. That doesn't mean that there isn't potentially true therapeutic value of cannabis for some conditions in some people, and that it's potentially a less harmful medication than some of the other medications they may or may not be taking. That what it does mean, though, is that if you regulate something as a medical product, like a legal product, like our burgers, like our lettuce, like our Cheetos at the store, then you do change people's perceptions and norms of perceived harms or risks from the product. And that is potentially dangerous because there's not a single medication out there that doesn't have some potential adverse effects, whether you're talking about aspirin, potentially Advil. I remember going in for an appointment, my doctor saying, Rosalie, did you really increase your drinking lately? No, I played sports though, and I'd been taking a lot of Advil, and then I'd started seeing early signs of liver damage. How many consumers are aware? We're so quick to go to the medication, and it's good, but we have to think honestly about anything we consume.
Right.
There's trade-offs. So
right.
Setting up a regulatory structure that keeps people aware of that, I think, is helpful and informative, and it provides the pharmacist the opportunity to hand out that information to consumers. When you're talking about the actual products, again, in the U.S., there isn't much difference between the two. The testing in many of the adult use regulations, the testing and the like is just borrowed language from the medical market policies. And that's because they aren't sure what they should be doing. They don't have an FDA partner telling them this would be better for testing to ensure a safe product. That's not the case outside of the U.S. And so again, I think this is an area where we can learn something from the other experiments that are happening globally. Israel, cannabis is a medicine. You get it through the medical market. Same with the Netherlands. By the way, people are fascinated to know there's a legitimate medical market in the Netherlands, even though they have coffee shops. And patients go to the medical market to get their product because
I do know a lot about the Israeli products. They don't even grow their marijuana on the ground with the dirt. Okay, these are germ cells and germ limes that are, made in a sterile environment. But also, if you really talk, and this is, what Israel did not done. Their agriculture is, the number one in the world, but they did not study the side effects, right? Just like you said, everybody has side effects. No matter what drug you're going to give, Tylenol, you're going to have some people have side effects, adverse reactions. That if someone tells you that there's no adverse reactions, they're lying to you, right?
There's adverse reactions to salt.
Right, exactly.
Yeah.
Right. I testified in a case of a guy who drank too much water in jail and died. So you can have too much of anything. But there are harms, and if you talk to the people who are getting the medical cannabis in Israel and the patient, they're seeing addiction, and they're seeing the same thing that we did with opioids, where people want more and more and more, and it's not enough.
I think we're going to see over the next 15, 20 years kind of a shuffle in how we approach the medical side. There's a lot of interest, even in the U.S. with state regulators, in ensuring that certain products they know are being used by medical patients with seizures or MS, not being able to find their product once markets legalize.
But wait, you can't wait. If you talk about seizures, cannabis decreases the seizure threshold. And I'm seeing so many people who say they're taking marijuana for their seizures, and they're in the air with seizures.
Is it any cannabis, or is it the
if you look at the way I tell people to go for the science is look at the FDA label, right?
Right.
So if you look at the FDA label for Marinol, pure THC, low dose, it can cause seizures, decreases the seizure threshold. So, and we're seeing that what we know works for seizures is Epidiolex, pure CBD for babies.
CBD.
Those babies are not smoking pot.
Exactly. No, that's my point, though, is that consumers go in and say, I want a high CBD product because I'm going to be using it. And what is important is that if you're going to a dispensary and you say, I want a high CBD product, you don't necessarily know if there's any THC in there or not. And we were looking at some data in New York.
But I can't imagine any real doctor saying smoke pot for your seizures.
No, agreed. Okay. But we're talking, there's tinctures, there's things that you could take in medical like dosing. It's not just the flower material. In fact, New York, when they medicalized, didn't even allow the flower. So there are products that look
I don't know there's any science that says you should take even CBD for your, idiopathic seizure disorder.
The science is still ongoing on this.
I
The
know.
evidence is not conclusive. Agreed.
That's right. But that's where we are. There's no science that says from seizures, but yet, there's government policies that says, oh yeah, you could use this for your seizures.
Yep.
And that
Lots
just
of
creates
science
more
that
business
says,
for me.
lots of science saying you use it for glaucoma, or lots of states say use it for glaucoma, and there's zero evidence. So unfortunately, again, this is the case where the evidence, the needed science is slower, in part because these products are changing. How many studies have been done on the plant with seizures? No one would have done that. They would have extracted certain ingredients and come up with a solution, because then a stable dose of what you're getting of different ingredients. And those studies aren't even conclusive, as you said. Epidiolex studies the evidence is not as clear as initially was.
So what are the best, before we get off the marijuana topic, what are the best policies you've seen from around the world regarding cannabis?
The first one is capping potency of products. I think that is a very valuable thing to do. Many of the jurisdictions that were doing this, Uruguay, Canada, capped potency on edibles. Not all, although there's new conversations about vaping. I want to say vaping products are capped at 60%. Or is that Vermont? I might be mixing Vermont. I think policies that place limits, even if they are seemingly quite high by some people's perspective, I think are helpful, because they're at least starting to pay attention to the risks associated with a completely unlimited product. I think the second most valuable policy that could be in place is pre-approval of any product that goes on the market. Europe has been doing this, or trying to do this, for CBD products, and actually had to stop taking new applications for CBD-based products.
Oh, and that would help with all that Delta 8, Delta 10,
Exactly. If there's a pre-approval process of a product, then we know what's in it. And if we start to see a few rare events, or we see a really bad case in a given area, you can identify, was it an ingredient in the product, or was it a bad, maybe something got into a certain pack. There's so many things with normal products that can cause a negative event. How much of this is cannabis, and how much of this was exposure and it got mold on it or something? We need to be able to distinguish those two, to be able to then attribute a particular health event to the cannabis ingredient itself versus just how it's grown. What was the pesticide on it? What were the new additive ingredients, and were those the problem? If we know what is in these products, we'll have a better way of identifying those factors.
Wow, that's very smart. Is there anybody in the United States who's doing that?
There's a couple states that are starting to do it, but they don't do it systematically for all products. And so this is something that when I talk to various policymakers, and say, it is a difficult thing to do. You have to have good testing and evidence to show a regulator what the product is. And the other problem in the U.S. is they aren't using the same rules when they do require a pre-approval process. Some are pre-approval of the labeling and packaging, not the product itself. Others are pre-approval of only the edible product. And so this inconsistency, again, can lead to differential outcomes than the intent of the policy itself.
So potency, even if it's not as low as you want it to, and pre-approval product, love that. What about, and I don't know, I see it as a priority because I don't know anybody who doesn't care about babies. But what about protecting our children? And, every day we hear about a story of kids coming to the emergency department from school because somebody brought some pot products to school.
Yeah.
And these are kids, they're not giggling. They're encephalopathic in the ICU. They're serious consequences.
No, I mean, if it were me starting this whole thing over again, I would do something more akin to the Uruguay model, where only plant could be sold in especially, and in your way, these products can only be sold in the pharmacy. They are private pharmacies, but all products are checked. There's a cap on the potency of the flower. And then they have social clubs that are, you can register and say, if you're getting it in the pharmacy, you can either grow it at home or you can get it at a social club. The benefits of that sort of system is that you don't have marketing of products, the creation of edibles, the creation of these things that get put on shelves and marketed to
Or in
kids.
the food, in all our food supply.
A group in the social club might decide to use their cannabis allowance to create food that can be consumed at the social club. Again, you're not exposing then youth. So it's figuring out how to enable adults to do what they want to do, but at the same time protecting kids. The easier way of doing this is say, don't produce products that look anything like certain foods. You can do oil that you can then infuse in your own foods if that's what really how you want to consume. If you don't want to smoke, smoking is bad for you. If you want to use it in other ways, do it where it's measured and it's not in products that look like the things the kids are going to be eating or wanting. That's really where we have industry behaving inappropriately. And it's not everyone in the industry, but there are some bad actors here. And obviously it's dangerous for them.
Well, I mean, that shows so much better than what we have right now in the United States. And then there's the awareness, especially with mental health, because marijuana is different than other drugs. You're not going to, go to a party, drink some alcohol and have psychosis potentially permanently from that. And that possibility exists. Not everybody, but that risk is there.
Right. But we need to be able to communicate who's at risk and why they're at risk for people to understand that it applies to them. So many people, how many people unfortunately, how long did it take to get people to not drink and drive? Because they're not going to be in the accident. That happens to everybody else. There's unfortunately a consumerism approach that we think harm, and it's not, we know it's true for adolescents because this part of the brain is not yet developed, but it carries into adulthood for some adults. Always assumes that's bad stuff's going to happen to somebody else because they're in control when they really aren't necessarily in control. Obviously, somebody drinking impaired should not be driving, period. Took a real serious campaign for us to, plus the introduction of alternatives for that to change. And I think we're going to need that sort of education around cannabis and psychosis for sure.
Although I think protecting your brain from all drugs, tobacco, alcohol, marijuana, whatever, until you're 25 years old, that's the gold standard. We should be able to say that. We should be able to say that.
And that's what I said to my kids when they were those ages. They didn't always listen, though.
I told my kids 27, though. I gave them 25. An extra 2 years. You work on other drugs, not just cannabis. That was interesting. Some of the other things that you're doing with. So
I'm part of. While I was at RAND, a group of our colleagues at RAND, we were able to get, and I supported a Center of Excellence on opioid policy, tools and information. And again, there's behind this, obviously, the opioid crisis is a big concern with people, the death rate the way it is. But there was a lot of bad science being done in looking at associations and evaluating some of the policies, forgetting that there were a whole bunch of other policies also taking place at the same time. So attributing, for example, the adoption of a marijuana policy, that causing a reduction in opioid-related deaths seemed to many people like a silly idea when cannabis is being used by such a small share of the population medically. If cannabis is reducing some of this opioid use that they were using medically, you're talking about such a small share of the population. Well, how does this happen? And some of this is because within healthcare systems, there was a whole bunch of other things healthcare systems were doing to reduce prescribing. And some of that got attributed to marijuana policies inappropriately because our data wasn't sufficient to capture all of this. So again, the Opioid Policy Tools and Information Center is really driven to try to educate people about the variety of different approaches that are being used by states to try to tackle the problem, to help people who are doing the research on it do a better job of capturing the whole environment and not just pieces of the environment, so they can appropriately attribute changes to the policies that are driving. So
I'm wondering if you ever do research, and again, this is something that we also just kind of talked about, the season finale. We're spending more and more billions of dollars on the whole drug crisis, record number. And we're not seeing a return on investment, to use economy language. The deaths are not going down; they're going up. Maybe flattening, but they're not back to the good old days where we had an opioid prescription epidemic. Are we investing correctly? So there's
question.
investment in supply and demand, and now there's a whole new concept of harm reduction with billions of dollars going through that. I feel like we have a fundamental problem in how we're distributing this money and our efforts, because obviously what we're doing now is not working.
I don't disagree. I think it's a great question. I don't think it's unique to our drug problem. If you think about obesity and the crisis that we've had in the U.S., we've had very much the same problem. Spending a lot of money on treatments for people after they've already become, diabetic, and we have to try to prevent them from having all the complications. If it's tied to diet, with huge initiatives. I think fundamentally,
I like your analogy, like a gastric bypass surgery for everyone,
Yeah, our healthcare system isn't giving the appropriate attention to prevention. And it's not because we aren't spending any money on it. It's because prevention is a wide-ranging group of strategies and approaches. And some of those approaches are going to work really well in some groups and not work at all in other groups. Just like some medications work well in some groups and not in other groups. And we can't study that quite as precisely as we can with medications, again. And so it doesn't get the attention and the focus that it deserves, that would help guide the dollars there. While I was at RAND, we did this study about the cost effectiveness of prevention versus supply side strategies.
That was a great study.
So what we found is that prevention is really cost effective. It's not very effective, but it's very cost effective. We have to figure out how to make it more effective. And it's not that prevention doesn't work. Some prevention works incredibly well, but it's that we can't take and diffuse what works well in one community and assume it's going to work well in the next community. There's cultural factors, there's social factors, there's environmental factors that can make that same prevention.
But I love your obesity. I love your obesity analogy, because we could put all our effort on, insulin pumps and gastric bypass
and treating,
surgery,
right?
Or we could teach, exercise and the importance of exercise and diet when you're young, and invest there. And you need both. You can't have one without the other, of course,
So where's the industry innovation going to happen? Where is the profit going to happen? I think part of the problem is that the market economy is enticing business and industry to be innovative on the things they're going to get paid really well for.
That's true. That's the same analogy, right? We got better surgeries now, better laparoscopes,
right?
That cost a lot more money, and
it's one of the side effects of the market economy. We actually need to use public dollars to fund a lot of prevention, because there isn't as much industry return.
Yeah, that's very interesting. All right, final words, conclusion. What's the best balance in drug policy? What have you learned over the years? What should be doing? What should we be doing as America to get us out of this mess?
We do need to invest more on effective prevention. We need to determine within communities what is going to be the most effective at encouraging adolescents to wait in taking and trying these substances, encouraging parents to understand that, offering your kids cannabis instead of alcohol is a good decision. That's not necessarily the case, but I can tell you, raising my kids, that happened on several occasions. We need to provide better education and prevention strategies deaths, but we can't ignore people are dying today. And part of the reason why they're dying is because they are going to an illicit market to buy goods. These medications that are made safely aren't necessarily the things that are getting diverted to the illicit marketing. It's new, innovative products. That's fundamentally different than the illicit market 20 years ago, 15 years ago. And that's dangerous. Unknown products being consumed are always higher risk. And that unfortunately is how we need to educate, again, consumer. Going to the illicit market, while it's really easy to do because of technology, it isn't unacceptable. Nobody needs to know about it. It's very, very okay. It's the lack of certainty and quality of products that's the concern. A colleague of mine actually had an idea of helping increase the uncertainty of the products out there on the market by just putting a bunch of junk out there, labeling it as something and having nothing in it. The question is, what can you put in there that's not going to be harmful in large doses if it's not an intoxicant? Just to try to break up the functioning, because the illicit market is a lot of reputation and relational stuff. So you try to break up that reputation and relation to try to reduce people's willingness to go there. But fundamentally, what we need to do is I think, approach the problem not just as a drug problem, but as a behavioral health problem. We are not addressing many of the issues in our lives very well. We need to promote more positive ways of managing our stress, of dealing with uncertainty, the stress, anxiety, and the like, and not looking for quick fixes. And that requires a toughening up that our society hasn't had in a while. Other cultures have had because they live in war zones. They live in rougher environments, and they aren't as willing to turn to quick fixes as we are.
Yeah, and that takes us back to the beginning of our conversation. What it is about our culture is that we need to teach at a very young age how to deal with anxiety, discomfort, life's problems in healthy ways and not rush to drugs. It amazes me how, I've had several podcasts where people are developing new technologies, new drugs, and the process that they have to go through FDA approval to make sure everything is safe and tested on animals and phase 1, phase 2 drug studies. And yet we have all these like Delta products, psychedelics, not ever tested in rats or mice ever, but they're tested first on our children, our population. I don't understand how that could happen.
If we can appeal to, appeal to mothers. How many moms were making their baby food at home because they didn't want any of the bad ingredients that might be in a Gerber bottle? That if we just
we're
make
so careful about some things, and yet we're like, what's going on?
Yeah, I think we need to do a better job of just conveying. It's not. I'm not saying cannabis is fentanyl. It's certainly not fentanyl. But you don't know what you're getting in the illicit market. If you go to the store, you can have better information, and hopefully as states improve their regulations, really good information about what you're consuming and make an informed choice. That's a much better decision.
Yeah. Dr. Rosalie Liccardo Pacula, thank you so very much for joining us, educating us, and bringing the perspective, drug policy, economies, marketing. Thank you. Thank you so much. And hopefully I'll see you in Vienna.
Sounds good. Thanks for having me.
Thank you for listening to High Truths on Drugs and Addiction, where you learn from experts from around the globe and around all aspects of drugs and addiction. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to Physicians for Healthy Communities. Visit physiciansforhealthycommunities.org and view their video and resource library. High Truths producer is Dave Rivas from Davey Boy Productions. I'm your host, Dr. Ronit Lev. We hope we brought your day a little bit more High Truths.